why does 51% of the population face obstacles to getting the care they deserve? Now, we know women in the UK do live on average longer than men, but they spend a greater proportion of their lives in ill health and with disability. And it's widely accepted, I think, now that the health and care systems that we all live with were designed with a male as default principle or approach, i.e. designed by men for men. So we know that there are knowledge gaps about certain conditions, for example, menopause and endometriosis, but also gaps in our understanding of how common conditions affect different people, cardiovascular disease, dementia, mental health, for example. So the question that I'm essentially asking is, what is the problem and what should happen and what is happening? And we've got a really top panel to discuss this with us this afternoon. I'll get them to introduce themselves and talk a bit about themselves in just a moment. But here's an appeal. I really do want this session to be a session about you interacting with the experts, you making the observations, you asking the questions. I will have my trusty iPad ready, and it's there, not as last year backstage now, so we're all set. But let's first of all meet our panel. And remember, you can post your questions online, and I'll get them on the iPad. And remember, raise your hands if you want to talk in the audience. So let's meet the panel, and I'll get them to introduce themselves in the order they're sat here. And I'll start with Amy.
Hi, everyone. I'm very pleased to be here. I'm a professor of maternal and child health at Swansea University and lead a research centre called LIFT, which stands for Lactation, Infant Feeding and Translation. So my research covers right the early part of the lifespan, so pregnancy, birth, early parenting.
And why does it matter, this?
Oh, gosh. We've only got a few minutes to talk about this, but it matters because every single one of us is affected by our mother's health and well-being during pregnancy, birth, and those early weeks and months. But I think the figure is less than 2% of all research funding is spent on pregnancy, birth, and reproductive health in general. There's a real lack of diverse research within that, especially considering the experiences of women from different ethnic backgrounds, disability, neurodiversity. But we know women are really affected. We have at least 1 in 4 women experiencing depression and anxiety during pregnancy, after birth, a similar number experiencing birth trauma. The figures suggest 80, even 90% of women who stop breastfeeding in the early weeks didn't want to do so and are left with a lot of anger and grief around that. We know there are still huge gaps in this area, particularly around medications in pregnancy and with breastfeeding, often leading women to be told, well, you can't take that medication, or you have to choose between breastfeeding your baby and taking it, and our research shows they just simply often don't take it, exacerbating problems.
We'll talk more about that in a moment. Carol, if I could ask you to tell people who you are and why do you think this is important?
Okay. Pnawn da pawb. So I'm Carol Davies. I'm a social care economist based at the Centre for Health, Economics and Medicine's Evaluation at Bangor University. And for me, this is really important to reduce structural inequalities that are impacting on women's ability to access healthcare at the same level as men. We need to identify, explore and enhance our knowledge around the impact of harmful gendered social norms on women's health and women's rights, because we need to begin to build the evidence, identify, explore and advance the evidence to influence research, policy and practice, so that we're building that based on our understanding of women's living experiences of accessing healthcare to reduce those disparities and look at being that more inclusive, so that we're understanding diverse needs and intersectional needs.
Diolch yn fawr, Carol. Rebecca.
Hi, so thank you for inviting me. I'm Rebecca Jones and I work at the Association for the British Pharmaceutical Industry. So Our mission is really around making the UK the best place in the world to research, develop, and then use future medicines. And my job as Director of Research and Development Policy is really around making sure that those medicines and vaccines work for everyone across society, and how can we do that with our research and development work. So obviously, everyone across society means ethnicity, it means age, it means gender. And I think particularly for women, age and gender is very important. Your biology when you're 16 is very different from your biology when you're 60. So how can we bear that in mind as we are researching and developing those new medicines and vaccines? So I think clinical trials is particularly important there, and an area where we have quite a lot of things going on and quite a lot of opportunity. So I'm coming at it very much from that sort of early development stage.
There we are. And finally, not least, Helen.
Thank you very much. So my name's Helen Monroe. I'm a consultant in sexual reproductive healthcare in Hywel Dda. I'm also a clinical lead within the NHS Executive, clinical lead for the Women's Health Network, and I also have the privilege of having a Health and Care Research Wales Research Time Award that allows me to develop my interest in women's health research. So why is this important in terms of a subject? Well, I think first and foremost, as a clinician, it's so important because I spend my day in, day out, talking to women around their health and choices to be able to manage different symptoms and conditions. And increasingly, particularly in the area that I work now, which is menopause care, I'm having to say to women, well, we maybe don't have as much evidence in this area, or perhaps that evidence is conflicting. And it's very difficult to have those shared decision-making consultations with women when we lack that robust, high-quality evidence. And I think, secondly, as the clinical lead for the Women's Health Network in Wales, and as we're about to publish our first draft of the Women's Health Plan, it's important that we think about how we embed women's health research into the development of that plan and the delivery of that plan, and that vision for the plan, which is for 10 years, and how we ensure that it is evidence-based moving forward, and we have good, robust ways of process evaluation and monitoring within that to ensure that we're improving women's health here in Wales.
Thank you all very much indeed. I'll start the discussion while people get up to speed and start thinking of their big questions and observations. But let's start with you, Helen. Obviously, the new Women's Health Plan for Wales is important. It's taken a bit of time to put together, but it's better to, I suppose, to get it right than rush it out. So that naturally, by having need for that plan, recognises the challenge. What I want to get a sense from you as a panel is, how has this challenge evolved and come about? And what can we do immediately to make things a little bit fairer or better? Helen, starting with you.
I think we're doing it here today. We're having the conversation, and that's so important. So we're raising awareness around the fact that there has been that gap when it comes to women's health research specifically. And as we've heard from many of our contributors today, is that actually if you improve the health for women and girls, you're actually going to improve the health of a population. And so that's incredibly important. And I think what I found when looking at the plan and the development of the plan is that importance around good data and good data collection. And I think that's certainly a start that we need to have here within Wales, and asking around that disaggregation of data. Often when I ask colleagues, is there a difference in the way that women are managed in your particular specialty? Their first response is, no, there's no difference. And then I ask, do you disaggregate your data? No. How do you know then that there's no difference? And so it's bringing up that awareness with colleagues, and that's at a strategic level, but it's also from that grassroots up. So it's having those conversations and then starting nudging and saying, well, are you collecting the right data?
Yeah, it was interesting in the session I went in at lunchtime, in terms of a couple of takeaways for me, is that improving our understanding of women's health issues benefits men as well, to a certain degree, because you can have that insight that you wouldn't have before. And the fact that, the data just wasn't interrogated or wasn't even actually captured before. So there's a bit about research there. Does that translate then into service provision, into accessing services, into what real world patients and people who use services feel? Is that gap in research across the board?
I think that research into practice is a difficult part.
Right.
But it's something that myself as a clinician is very much aware of the need for. And I think by removing that unconscious bias, we start to raise awareness and we can make change.
So is it just a case of, well, it isn't, I'm answering my own question, it's not just a case of getting more women involved or getting more studies about that. It's about a culture change, a societal change, a way of doing things change. Feel free to chip in.
I think it's about really addressing some of those inequalities and those harmful gendered social norms. But it's kind of linking with our discussion in the previous Women's Health panel. If we can't sell that need to be a more diverse, needs-led society, more inclusive society that's focused on social justice, if we're looking at the economic case here, there's a strong economic case and that best value case to be able to address the women's health needs. We know from evidence that if we increase cervical screening care for women, that we're saving the NHS 10 million if we're reaching that over 80% in screening. Our screening at the moment in Wales is under 70%. So we know that improving access to healthcare actually saves money, and promoting those maybe lower cost options, preventative health, is better for the needs of women, but also it's better financial value as well.
So do we say that things are just nowhere near where they need to be at the moment across the board? That things are poor? We're talking about it, but what would you think about, you know, the urgency of the need to address some of these issues?
I think there is an urgency.
Yeah.
We're looking at having one of the biggest women's health gap in the G20. So I think there is the urgency, but I think having the conversation today, as Helen was mentioning, is an excellent starting point.
In the session I was in before as well, I was talking about funding research and getting them to change their mindset and to look at these issues, but also, you know, pharmaceutical companies we know do a lot of research and depend on a lot of research. From your perspective then, what do you think?
Absolutely. I think in terms of us being able to ensure that we're working alongside industry, as well as the many academic institutes that we have here within Wales, to ensure that we're embedding that research within our policy development is so important. And I think there is that motivation and a drive to see it happen.
But Rebecca, you live and breathe this space, don't you? Give us your perspective.
So I think it is important, and I think it's something that we're thinking about, we're increasingly thinking about. I found the session this morning really, really useful, particularly the way, for me, it brought together that kind of discovery, preclinical part of medicines and vaccine development, and then also looked at kind of clinical research. And I think this is an area where we're going to see increasing focus and where we have an opportunity to change things. So we know there's going to be new legislation. MHRA are doing new clinical trials legislation imminently, and there will be inclusivity and diversity guidance that goes alongside that from the HRA. So that's really positive. I think there's something about that, about embedding that, looking at that. But I think we're also, you know, we're also investing in clinical trials infrastructure through the new medicines deal and the investment program that goes alongside that. There's up to 300 million there for clinical trials, kind of infrastructure and resources. How can we, let's think about how we do that in a way that thinks about diversity and inclusion. So that's sort of 300 million UK wide, but obviously there's a significant amount coming to Wales that's going to go into some commercial research delivery centres. There's going to be another tranche of funding that's for things like staffing, infrastructure, details to be confirmed. But there are these things that are coming down the road at us that we can use to change things.
And Amy, just in terms of the work you do, are you sensing a gradual shift here?
I think we are seeing a gradual shift. It's one of those things that if you look back to last year, you probably can't see a change, but if you look back 10 years, there's a bigger change.
Give us a sense of that.
I think there's a lot more understanding around mental health, for example, around pregnancy and birth and feeding babies and being a new mother than there was certainly 10 years ago and certainly 20 years ago. there's more discussion. It's helped by social media. It's helped by increasing connectivity and people talking about their experiences. So it's a case of more research being done, but also more experiences being shared and the collaboration between that in a way.
Okay.
I was going to say, and that's so important. So if you think about the area of menopause, for example, you know, I think that it's been a little bit of a double-edged sword when we think about the high-profile celebrities who have really led the way in talking about the menopause. But I think in many ways it's also broken down the stigma around talking around that important part of a woman's life. And it means that we can actually open up those conversations within our health services to go, well, are we providing a menopause service? Are we meeting the needs of 51% of the population in this important time of their life, which we know has such a huge impact on the quality of their life, their ability to work, and the impacts of that to society as a whole. So actually, I think, yes, we've got so much to do, but what I'm hearing and seeing is there's pockets of innovation that's happening, particularly in primary care, where GPs are stepping up and doing things differently to make a difference. So I think there's definitely some hope there.
Okay, I'll open it up to the hall in just a moment. I haven't had any questions on my iPad yet, so come on, please. Couple of quick fire ones, and butt in, whoever wants to kind of answer these can do so. If it's a system designed by men for men, does it take women to change it?
Can I add something here? That I think you've got a circular problem with women's health research, that we know women are less likely to receive research funding, we know women are more likely to research women's health, and we know that men are more likely to shy away from it because it's seen as women's issues. So it carries on with men getting the funding to do the big problems that affect men's health. To change that.
Go ahead.
I think for me it needs to be an inclusive approach, because if we're talking about here structural inequalities and harmful gender norms, to change that landscape, we're going to need to ask men to give up a level of their power. So for us to need to do that, we need to have the conversation with everyone. And as Helen was saying, reduce the stigma and the shame around talking about periods, the menopause, you know, so we need to change the conversation and the landscape.
To change the conversation, what's the incentive to do that?
I think it's building on what we've discussed around the well-being of women is for the benefit of everyone. But also, as I mentioned, if we're not focusing on that social justice approach, it's very clear from the evidence that there's an economic case here to be improving the outcomes and the well-being and health outcomes for women, and understanding some of those barriers to accessing healthcare by building an approach that's more compassionate to the diverse needs of women.
And I think you'll all agree there are men allies, male allies for you it's people that would be advocating the similar things as well. But maybe going earlier on in terms of somebody's medical education or healthcare education or any kind of staff, are these kind of biases ingrained from the start? Do we need to look further down the supply chain, if you like?
Absolutely, and I think that's part of where we need to be bringing in some more of that inclusive conversation when we look at our undergraduate students. If I think of my own medical education at medical school, when it comes to something like contraception and sexual health, I think there was less than half an afternoon that was designated to talking about that. And now I've built a career around it, and it's so holistic and it touches every part of our lives in terms of our sexual and reproductive health. It's so important. So we need to change from those educational aspects as well.
Okay, yeah.
And I think that needs to start in primary school with children, having a whole community approach to understanding diversity, gender and healthy relationships as a whole. A lot of the work that I've done has focused on gendered social norms and the impact of violence and abuse on women. So I think that education needs to be beyond even a whole school approach. It needs to be that whole community approach that everyone takes responsibility for.
There we are, right. There's got to be some questions in the hall now. Okay, just over here. And if you could introduce yourself as you're asking the question or making the observation, that'd be brilliant.
Hi, thanks. My name's Catherine from Impact Improving Adult Care Together. And my question was around, is there any research on whether hormonal birth control can impact long-term mental health conditions or mood disorders? Thanks.
Quite a specific one.
That's a very specific one. I'm happy to give some comment on that. So in one of my previous roles, I was Vice President of the Faculty of Sexual and Reproductive Healthcare, which is the main organisation that oversees the training and qualifications of doctors who work in contraception and sexual health in the UK. There have been some papers that have looked at it. When we think of contraception, and if you are to look at the SPC, so the medical readout on a contraception packet, it will talk about low mood. So I think it's important that we're aware of it, and it's important that we have those tailored consultations with women, particularly those who perhaps had a history of mental health and low mood, because we have more than one type of contraception available to us. And that's why having that consultation and that informed choice for that person is so important. There needs to be more, without a doubt. We need to be doing more research on hormones, and we use hormones a lot to manage women's reproductive needs and health issues and symptoms. So we definitely need to have more research into this area, but it is something that we are aware of, and the importance of that tailored consultation is paramount.
Another hand up, right in front of me.
Jack, yeah.
Go ahead.
My name is Jackie Boivin. I'm a professor at Cardiff University in reproductive health and women's health. This is a question, well, for the whole panel, but maybe with Prof. Davis first. How do you think health researchers can better work with social care researchers to tackle and address big problems like in-work poverty?
Yeah. So I think that's a key point, and something that I'm working in partnership across Health Economics Cymru to be influencing that interface between health and social care economics to measure value across both systems. Because for me, you can't measure the value in health without really beginning to measure the value and the impact and the outcomes in social care as well. So we need to improve the way that we're measuring outcomes and value in social care, which will then impact and be a positive influence on health. You know, they work together, it's that partnership, their services that very much influence each other. And this year is 25 years since I qualified as a social worker. It's an area I'm really passionate about promoting, and having that parity between health and social care is quite important to influence outcomes for women. I've just started a new research project last month around focusing on measuring the enhancement to cervical screening care for women living with the impact of sexual violence and sexual abuse across Wales, England and Australia. And the approach that I want to bring there is focusing on bringing that social care value and lens to building a compassionate care approach for women. So I think it's vital to have that really strong partnership between health and social care.
Okay. Hold on a second. Anybody else? Oh, one in the corner, and then I'll go for the iPad.
You may now have what is on the iPad. But I was thinking, I'll put it in.
Do you know, with a little bit of help from our friends over there, the iPad has woken up.
So I'm sort of coming from the postmenopausal part of all this. I have given birth to 6 children who are aged now 32 to 41. And I had, in the main, extremely good experiences of maternity services, postnatal care. The midwives were fantastic. But apart from one male obstetrician who was fantastic, I found the others, including women, medicalised it all and actually didn't seem to care about me as a person. And I'm just hoping that that may have changed. And also, I mean, I've got 7 grandkids, and I am appalled at the maternity care and support that my daughter and my daughter-in-laws have received now. It's nothing like I experienced 40 years ago. And and it really saddens me because they're not having a good experience. They're just fighting.
And if anybody follows the news, they'll know that is a big issue. Who wants to go on that one?
Yeah, there is a huge staffing crisis, as we know, in midwifery and health visiting, which has led to significant decreases in a lot of areas of different services. It was all affected by COVID. It was difficult to get some services back up running again, and it's really affecting the mental health of mothers and partners, but also the mental health of staff who want to provide the care that they are used to be able to providing. I think things are changing in terms of recognising mothers more in this. There are a lot, again, of quite prolific social media people talking about how traumatic and just life-changing motherhood is and how they need the care and support. People like Paloma Faith writing a book on the matter, and those people really reach new parents and they're changing the conversation. But again, it's finding that balance, isn't it, between how do we support everybody here, how do we increase funding and research into this system so that mum and baby can both be supported.
And my understanding is that the HIW, so Higher Education in Wales, has now done a workforce review around maternity and perinatal services. So hopefully that will build on some of that need.
And we know from the NHS Confederation report on women's economics health, which was launched this month, we know that there needs to be more investment in this area. And actually the evidence is reflecting if we spend £1 more in this area on women, then the return on investments will be £11. So again, there's that strong economic case here around investing more in this area.
Okay, so I'm going to go to the iPad, because I have one, and it'd be a shame not to use it. I won't ask you all to respond to every question, but if you do feel that you are best placed or really want to, please tell me, and I'll get you to answer it. First one is about endometriosis, the 7 to 10 years delay, perhaps in diagnosing. Is that just a lack of awareness amongst healthcare providers? Who's for that one?
I'm happy to start off with that one. So absolutely, we know that there is a delay in diagnosis, because that gold standard of diagnosis is around putting a camera inside the abdomen to have a look for endometriotic deposits, and there is a delay in terms of that waiting list. But we also know there's a delay that could be around the knowledge and understanding of the healthcare practitioner. And so there's a lot of work going on at the moment with endometriosis Cymru that Jackie, our colleague before, has been speaking about, is involved with. Fair Treatment for Women of Wales have also been strongly involved with. And as the Women's Health Network, we're looking to build on the work that they're doing to ensure that it promotes that better understanding amongst healthcare professionals, so that they can understand and help bring that diagnosis sooner. When it comes to more those tertiary or those complex services, we absolutely are aware that there's a shortage of those very skilled gynecologists. And so as the network, we'll be working with Welsh Government and the Joint Commission on Funding to be able to look at how we can set up some of those tertiary services to support women in Wales. So we absolutely are aware of the fact that, that this is unacceptable, that women are suffering and in pain, and it's about us working together to be able to make some changes in that short term.
Bringing it back to research, it follows on from the previous question, but this question is, do you think a barrier to research around, for example, endometriosis, contraception, has been due to societal stigma around women's periods and stigma around what contraception to use? Do you?
Absolutely. If you talk about a number of subjects in research grants over the years, it was immediately labelled as a woman's problem or a bit, stay away from that. We've had the same experience when talking about breastfeeding, which you would think would be something that we could all talk about, but again, we've often over the years tried to give it a wider focus and not mention those words so much, which is ridiculous when you say it out loud. But
I mean, I suppose part of the issue is about, you know, as I mentioned in the opening this morning, sometimes you think research is about the end product, the results, but actually it's about the people who do it and take part in it. And this is a question that's come in, is how do we gain trust with women and communities that are disengaged with the research? You know, build those bridges, make it... How do we gain trust?
Around the research,
Yeah.
I think as researchers we should never have the view that people are disengaged from research. There are communities and populations and women who are unheard. So for me it's about giving voice and having research designed with and for women, and that you're having that approach right from the outset.
I think there's also something about how do you involve women, for example, women in pregnancy in clinical trials. I know there's some work done by Birmingham Health Partners on that the ABPI was involved in, which was really around, and it looked at some of the details, like how do you ensure clinical trials with pregnant women. It found that there wasn't necessarily a lack of willingness to be involved, but it was more that there were other barriers. So I think that's part of it. And then I think the other part that's quite key is around how can we use things like decentralized trials? How can we take trials to women to make it easier for them to participate in it? So it's around taking those barriers down and making it easier to do.
And Rebecca, you love this. There's a question specifically for you. Yeah.
Okay.
The role of pharmaceutical companies in pioneering sex gender inclusive research is essential. What do pharma companies need to begin to make this change happen?
So I think that's an interesting one. I think we've certainly been thinking at the ABPI about diversity and inclusion in clinical trials, obviously involving women and ethnicity and age and other factors. We've actually got a patient council who work quite closely with our board and with sort of across our members, who are sort of major pharmaceutical companies, small and large. And it's something that we're actually thinking about sort of actively, so that we're organising a kind of a best practice workshop in probably Q1 next year, really overseen by that patient council, whose job is to bring that voice in. So we are thinking about that. I think there's also quite a lot of work. This diversity and inclusion guidance on clinical trials will be really useful and interesting. The HRA are bringing out where you're sort of embedding it in everyday practice, and I think that's key.
Right, any more from the floor? Right over there, yep.
Thank you so much, that's fascinating. My name's Kate Womersley, and my question is about the women's health hubs that have been the centrepiece of the women's health strategy in England. But we've recently heard that funding won't extend beyond March 2025. Obviously, it's great for governments to be able to use these kinds of examples as PR for themselves, and it looks good and it's a quick win. But how can we make sure that women's health is a sustained commitment rather than just a headline grabber?
I'm happy to take that one.
Go for it.
Thank you for bringing that up. Women's Health Hubs. So last Monday, the Women's Health Network hosted a stakeholder event where we brought together 60 colleagues from across the different health boards, primary and secondary care, to talk about women's health hubs. Because we're very much aware of this £25 million that has been put behind the development of women's health hubs in England. And there is discussion happening as to whether these should be coming into Wales. But they mean things to different people, and sometimes they're physically based, but other times they're remote. And I think we have specific populations here in Wales, particularly around our rurality, which means that a physical hub may not necessarily answer the questions or meet the demand or help us meet the challenges that we have in Wales. And so we've started that conversation around women's health hubs in Wales, and part of that is around that sustainability of finances, because it's important that we look at each health board differently in terms of what their needs are, and we ensure that actually looking at where the gaps are in provision of women's health is being met in a complete way and not just in a tick box way. So we're having those conversations within the Women's Health Network and looking at potentially scoping for women's health hubs over these next few months. But we will be calling upon our patients, those with lived and learnt experiences, asking our colleagues in research and academic institutes to help us to do that piece of work, because it's important that we actually make it very specific to Wales, and we don't just want to transplant models that have come from England. So it's very much watch this space when it comes to health hubs.
Well, there's two hands quite near each other, right in the centre there, so let's get both questions at the same time if we could, and we'll get the panel to respond. Just to the...
Thanks, Tony Cope. I just wanted to ask, so my biggest intersection is disability, and obviously there's a medicalised model and there's a social model of disability, and it's been found that the social model of disability is more acceptable to disabled people, and it's been quite transformational. I was thinking, much of this work is medicalised, so it's medicalised women's health, medicalised men's health. Does the panel think that what we actually need is a social model of gender roles and sexuality?
Hold that thought for a moment. Could I have the question from behind as well?
Hello, mine was a bit more specific, just about the hubs. Do you want to go back on that point before I change the conversation again?
Okay, so ask the question,
Okay.
And then we'll come to it.
Helen, it was just building on your point around hub terminology, because we know that there are hubs in social care space. So there was a big drive from Welsh Government around RIF funding, that RIF was used towards hubs, and then also in the mental health sphere. So I'm working the NHS Executive Strategic Programme for Mental Health. So I guess it's just a plea, really, that even though absolutely pinched with pride models in England, it's also about tapping into our local assets and not continuing to silo areas where, you know, we could have mental health and social care hubs and women's health hubs all providing improved outcomes for women. So it would be great to link in with you on that.
We've only got about 5 minutes left, so I'll try and let's wrap the hub issue, because I know in many of things, hubs can mean different things to different people.
They can, and you're absolutely right, and we are having those conversations across Public Health Wales around different models that we could hook into, particularly around the accelerated cluster development work that's going on in primary care. So we are trying to join the dots.
And the question before about the models, the way we think about these things.
I'm happy to kick that. I think you're right. It's thinking about those social models of delivery around healthcare and social prescribing. And I know that my colleagues in primary care are probably very much further advanced in this in terms of thinking around those social models of care. So I absolutely feel that the medicalisation is an area that we need to be mindful of when thinking about alternative models of care. So it is part of the conversation that we're having, particularly within the Women's Health Network, and how we can use those social models of care, social prescribing, again within my area of menopause care. And I think there's so many other areas that we could be utilising it as well. So thank you.
Yeah. I think that's a really important question that you asked, and I worked in the learning disability services for many years and saw that the social model was what citizens wanted, was what multidisciplinary wanted, and what worked really well around achieving person-centred outcomes for people accessing support. So I think that's a really important point.
We're almost at an end, but I'd like to ask all the panel this question. I know it's difficult because I once went to a talk where Professor Sir Michael Marmot was doing it, and he's done a lot of work on life expectancy, social determinants of health, and somebody on the telly, journalist, asked him, what's the most important bit of this? And he goes, well, it's all important, but well, give us the top 3 most important things of what you're saying. And he goes, well, it's all important, but the journalist in me can't resist a what's the most important bit of this type question. And I've got an excuse because it's one of the questions that's come up on the iPad. So if you could, what one thing would you change in the system to increase women's health research and, by definition, I suppose, make the outcomes better for women? What would you change, or what can you change? Starting with you.
I'm going to be really biased, but I'm going to say we need to invest in terms of health and services right at the start. so we invest in pregnancy and birth and see the benefits going forward.
Carol?
I think we need to access diverse voices of women across communities. So going to the earlier point I made around, it's about understanding unheard voices and taking responsibility as researchers to do that, so that we're building research for and with women, and we're co-producing those research ideas from the outset with women and with specialist services supporting women.
So for me, I think it's around making sure that we have women involved in research, in doing the research and participating in the research and thinking what the barriers to that are. And that's not just research, well, that's obviously really important that that's research around menopause, around pregnancy, and gynecological conditions, but also across all research, because women will respond differently to different conditions. They'll respond differently to the medicines. And then there's other conditions where women are overrepresented if you look the higher proportion of women are affected. So I think it just needs to be sort of embedded throughout, really, so we pick all that up.
And finally on that point, Helen.
To me, it's asking one question. What does this mean for women? And it doesn't matter if it's around women's health, if it's about designing a new building with the number of toilets that you have, it's whether the road access, the bus access, what does this mean for women?
Can I then quickly ask you, following on that, what does it mean for women? This isn't part of the challenge here to persuade what does it mean for everybody in terms of better insight into whatever will benefit men equally, potentially. How do you get that message across? Because people might say, oh, it's another discussion about women's health, or it's another thing that I, by definition, shouldn't be bothered about.
You make it personal. I think that's what we started out with. Mothers, sisters, children, daughters. We all have important people in our lives who are women. And I think it's important to then always bring the story back to how it can make a difference to family members. And it brings in that compassion question, which I think is where we need to have the heart of patients.
So again, it's about the person, the person at the centre of it all. Do you agree?
Yeah, and I think building on that, it needs to be focused on that compassionate approach for women. And if people don't find that argument persuasive, then it's that investing in health will eventually save money. So it's that economic case as well.
Amy?
I can't add anything to that. I don't think I think it was Melinda Gates who said, invest in women if you want to make a difference. And that's the very simple message.
And final word, Rebecca?
So definitely, it's definitely about thinking about people, but there's also a huge economic case as well as that impact on every person and people we all know. I think it was the World Economic Forum recent report that if we close the women's health gap, it would add, was it 1 trillion to the economy each annum by 2040? So it's personal and it makes economic sense.
There we are. Perfect. Could I ask you to thank the panel, Amy, Carol, Rebecca and Helen. Thank you ever so much.